My name is Dr. Stephen David Watson. I've been performing a minimally invasive spine procedure in the neck, mid-back, and the low back for the last 10 years. This procedure works well to treat the pain that patients will have in their spine, as well as treating the pain that many patients have in their heads. These severe headaches that occur to a significant part of our population. The first part of this discussion will be based upon a formal journal article presented in the Journal of Anatomy in 2010, discussing the pathophysiology. And the second part of the discussion will be talking about the procedure I do and what I expect it to do and how I expect it to relieve pain and the pain in the head that patients will feel at times. First of all, it's important to understand disc anatomy. The discs are made up of a nucleus and the annulus. The nucleus is a material that is a gelatinous substance in consistency. It has the consistency of something like 90-weight oil in the winter in Alaska. In other words, you can squeeze it or squish it or smush it, if you will, on one side, but that has to be contained, and so therefore the pressure when you bend forward or flex your neck, your low back, has to be contained, and it is contained by the annulus fibrosus, which is a series of wrappings of collagen fibers, 16 to 20 in the low back, lumbar spine, and fewer than that in the cervical spine. When we look at a normal disc, we find that in a healthy young person, for instance a 12 or 14-year-old, those discs typically do not have any blood vessels or nerves whatsoever. If they are innervated, they will be primarily nociceptors or pain receptors and a few proprioceptors. This is just to have the idea of what a normal disc looks like. There will be very few nerves in the posterior aspect of the disc to a few. Usually they will stop at the junction of the outer one-third to the middle one-third of the annulus. Once in a while, one of these nerves or nociceptors will penetrate into the nucleus. When we look at injured discs, we find that they are hyperinnervated versus a normal disc. The cause of this is the release of growth factors called neurotrophins. And the typical neurotrophins we think about are nerve growth factor itself and brain-derived neurotrophin factor. Neurotrophins and their receptors are found in normal and innervated disc. The density of these compounds and the receptors are clearly higher in injured disc and in the disc of patients who have been formally diagnosed as having discogenic pain. The density of innervation is clearly proportional to levels of neurotrophins and their receptors. Neurotrophins are synthesized within the intervertebral disc. They are transported retrogradely to the dorsal root ganglia in sensory neurons, and there they upregulate neuropeptides such as substance P and calcitonin gene-related peptide. Neurotrophins are also produced in the dorsal root ganglia and transported antegradially to the dorsal horn of the spinal cord. That's laminae 1 and 2. That is the marginal nucleus and the substantia gelatinosa, respectively. There they influence the synaptic transmission in the dorsal horn. It's also important to know that nerve growth factor and brain-derived neurotrophin factor are always produced in painful discs. Now, nerve growth factor the production and release are stimulated by the interleukins as well as tumor necrosis factor. There are clearly higher levels of these compounds within an injured disc versus a normal disc. And anytime nerve growth factor is found in a cell, it increases pain perception. Nerve growth factor production and release is important, and we need to understand the function of such chemicals as substance P and calcitonin gene-related peptides. These are inflammatory mediators. They are released at the nerve terminal in the environment of nerve growth factor. They cause neurogenic inflammation by released from mast cells. And there are an increased number as well of brain-derived neurotrophin factor neurons in laminae 1 and 2, and all of this causes pain amplification. These substances being released from mast cells in the environment of nerve growth factor around the disc annulus itself can cause inflammatory changes in the segmental nerves as they pass by, resulting in likely in radicular symptoms, as well as increasing or amping up or amplifying the inflammatory changes within the posterior annulus itself, and all of this resulting in greater pain perception in the patient. Now, when you look at innervation of the disc, the nerves innervating the disc are branches of the sinovertebral nerve primarily. These are clearly segmental. Rat studies show that, for instance, the L4-5 and L5-S1 disc are innervated by nerves that have their cell bodies at the L1-2 level. Human studies, as far as they go, showed similar findings, And it was because of this that the procedure was promulgated about 10 to 15 years ago, suggesting that an L1-2 sympathectomy be done bilaterally in the patient to try to diminish their discogenic pain. My name is Dr. Stephen David Watson. I've been performing a minimally invasive spine procedure in the neck, mid-back, and the low back for the last 10 years. This procedure works well to treat the pain that patients will have in their spine, as well as treating the pain that many patients have in their heads. These severe headaches that occur to a significant part of our population. The first part of this discussion will be based upon a formal journal article presented in the Journal of Anatomy in 2010. Now, looking at the chemical structure of the disc, most important, we find that the nucleus is made up of a glycoprotein. That's called an aggrecan. It is mildly acidic. It is a long-chain sugar molecule with proteins attached to the sugars. And in the healthy disc, these are negatively charged and attract water electrostatically. And it's because of the fact that they attract water that when you look at a T2 weighted scan of an MRI, looking at a healthy disc, the disc will be white, just like the cerebrospinal fluid. As the disc is injured, it progressively will shorten, become shorter. The height will go away, as well as it becomes darker and ends up black when it is very badly injured. Clearly then also there beside the nucleus is the annulus, which has 16 to 20 wrappings in the lumbar spine and fewer than that in the cervical spine. When we look at discogenic pain causes, we have to know that in injured or degenerated disc, the annulus becomes vascularized, and these nociceptors accompany vessels into the outer one-third of the annulus, and these are branches of the sinovertebral nerve. The injury sequence occurs over a period of time with smaller injuries, or it can occur with a single injury. For instance, the person working on an assembly line who turns, twists, bends, and lifts a heavy weight of hundreds of pounds and hears a loud pop or snap or whatever else like that and feels immediately severe pain in the low back and perhaps pain in the leg. What happens is, as you increase the pressure on the disc, you have this contained nuclear material that you mash down on it and increase the pressure by the laws of physics. We know that that pressure has to be distributed equally in opposite directions in every direction, and the annular fibers are there to contain the nuclear material pressure. If you increase the pressure by bending forward and lifting or having an accident to the point where the annular fiber's strength is not as much as the pressure in the nucleus, then those annular fibers can tear. And with each tear that occurs of those annular fibers as they tear from the inside out, eventually when the little nociceptors are touched by the nuclear material, which is acidic, the patient will feel pain. The patient will not have any pain early on, even though there has been an annular tear. Some of the nerves and blood vessels have grown into the back of the disc, but as long as those nerves are not being touched, the patient does not have pain, which is why this can occur with even a small injury at the time of an accident, because that person may very well have had prior injuries where annular fibers were torn in the inside coming out, but the nerves were not touched by the nuclear material, therefore they're not symptomatic until they have that final small motor vehicle accident or something like that, which now causes the pain. This again, a picture of a normal disc. Very, very few nerves in the posterior aspect of the annulus. This is a picture of the injured disc. Clearly a lot more nerves. It's not just twice as many, it's many times more, but the idea here is just to show that going from a normal disc to an injured disc, there's a lot more nerves that grow into the back of the disc. This is just a picture to show you the representation for a lumbar disc. This would happen to be at the T12L1 level or something like that. But the more important thing is looking at the annular fibers, 16 to 20 wrappings of collagen fibers around the nucleus, with the nuclear material being that material that has a consistency of 90 weight oil in the winter in Alaska. Now, as a physician, I want to look at that disc and see how much injury there has occurred. An intact annulus, intact nucleus, where there are no annular tears, is considered, if you will, a grade 0 annular tear. Although that term is not typically used. But we look at the inner one-third, middle one-third, and outer one-third of the annulus to see how bad the injury has happened. This obviously is an intact nucleus, intact annulus, no tear. This disc is normal. And you notice in the normal slide before this that there were no blood vessels and nerves. Once the injury starts in that disc, the annular fibers begin to tear from the inside out. Somehow or another, a signal goes to the spinal cord, most likely, and nerves and blood vessels now grow into the back of the disc because of the release of nerve growth factors. And now those nerves and blood vessels are sitting there trying to, if you will, trying to fix the disc, but you cannot fix your own disc. But still, you will not necessarily have pain at that point in time. Now you can have a further injury, and the tear extends further out in the annulus, and yet the nerves are not being touched. Therefore, the patient does not have pain. Notice, as soon as that tear extends into the outer one-third of the annulus, now the nerves are being touched, the nociceptors are being stimulated by the nuclear material, which is slightly acidic, and now the patient has pain. This is just a sequence to show you how this occurs over a period of time or instantly in an accident. As the tear, overpressurization of the nucleus occurs, the tear in the annular fibers from inside to outside occurs, and finally at the end of it, the nociceptors are being stimulated by the nuclear material and the patient feels pain. This was a picture of a cervical patient, a patient I operated on the cervical spine about 7 years ago. You can see there are 3 needles in the disc of the neck. This person is asleep, lying on an operating table. A fluoroscope is being used to take these images. That's an anterior-posterior image. This is a lateral image. Most important here, shows that I try to put the needle approximately 3/4 of the way back from front to back, and I try to put it far left, middle, and far right. I put some contrast in there to see what the disc looks like or how far back it goes in the canal, and then I place a measured amount of energy with a thulium laser at each of those 3 points to try to turn off or kill or denature the protein of the nerves, and all nerves are protein, and when you heat proteins above a certain point, 45, 46 degrees Celsius, they turn off or die, or they simply don't work, whatever. So I'm trying to put enough energy in there to turn off or kill or denature those nociceptors so they no longer take the signal to the brain saying there's pain. I'm also trying to seal the blood vessels that bring those inflammatory compounds such as substance P and calcitonin gene-related peptide to the disc. And I'm also trying to shrink the disc bulge or herniation, as I've been able to show does occur in some cases when I perform this procedure. This is a picture of a patient, gentleman in his early 70s, that I operated on 2 or 3 years ago. He had severe pain in his neck, headaches. He had pain, tingling, numbness, and weakness in his right arm. He was dropping things. He also had severe right leg pain. He had 5 bulges and herniations in his neck, with 3 of the herniations looking like a guillotine blade like this, extending back into his canal on the right-hand side. Within 4 days after the procedure, this gentleman came back to the office and said, quote, "I feel like I'm 20 years old again," unquote. He came back over a year later, and we've talked to him at about a year and a half out, and he was still doing very well from this procedure, with all of those symptoms being relieved. This is now a picture of what the procedure would look like in the neck. Now, this diagram here shows the patient lying down. In reality, when I'm doing a low back and a mid-back procedure, the person is lying on their stomach. When I'm working in the neck, the patient would be lying on their back on the operating table, asleep, but facing up. So this is upside down for the neck. But the point of it is, when I'm working in the neck, the patient is asleep, their neck is sterilized with soap solution, special soap solution. They are sterilely draped, and I'm using fluoroscopy or x-ray to find a specific location to put a needle down through a small incision in the skin of 2 or 3 millimeters and down into the soft tissue, through the soft tissue and into the disc. First of all, posteriorly 3/4 of the way back on the far left, then the middle, and then the right. And I put in a little bit of contrast again to see where the disc goes. Then I put in the measured amount of energy. As you see here, the nerves are being turned off or killed. The blood vessels, which we don't show in this picture, are being sealed so they can no longer bring those inflammatory compounds to the disc and into the disc itself. And finally, they are hopefully causing the disc bulge or herniation to shrink, thereby potentially relieving pressure on a segmental nerve, or at least by decreasing the inflammation in the canal to diminish the radicular symptoms that a patient might feel. Now, the final slide that I show is a reference to the Journal of Anatomy article that I used as a basis for the pathophysiology of what is going on in the spine to cause a patient to have pain, with the second part of the presentation being my procedure and how I expect it to work and what I expect it to do as far as relieving pain. and pain in the head for patients. Thank you very much.